Good evening. Thanks to Mary and the team for the introduction and for the invitation to speak here tonight. My name is Ciara Lyons. I'm a radiation oncologist in Waterford. I work with a team of radiation therapists and medical physicists to treat people with all kinds of cancer and occasionally people with other diagnoses. Tonight, I'm going to speak about the different kinds of skin cancers in Ireland and how we treat them. This is what I'm planning to cover. It's really an overview of where things are at in Ireland with a variety of different types of common skin cancers. Be warned, there will be some pictures along the way. It's really impossible to talk about this properly without showing you what I'm talking about. Any and all questions are welcome, as is your feedback. There'll be a question and answer session at the end. So firstly, what is skin cancer? Cancer fundamentally happens where cells begin to grow uncontrollably and eventually figure out how to move to other parts of the body. It can cause problems both where it begins and where it ends up. It can arise anywhere in the body and is treated in all kinds of different ways. Skin cancers can arise from any component of the skin, all the layers of the skin itself, the sweat glands, the hair follicles, and the number of people diagnosed with skin cancer in Ireland is rising rapidly. NCRI, the National Cancer Registry of Ireland, expects the average number of cases will probably double between 2015 and 2045. And we see that here in the next slide. It's broadly split into two main categories, melanoma and non-melanoma cancers, and these are dealt with quite differently. So non-melanoma skin cancer, essentially exactly what it's named, is by far the most common skin cancer in Ireland and worldwide, at over 90%, 9 in 10 of all skin cancers. By itself, it represents just over a quarter of overall cancer cases in Ireland in recent years, and there are many different types. The commonest by far are basal cell carcinoma, or BCC, and squamous cell carcinoma, or SCC, for a combined total of over 11,000 cases per year. Again, the NCRI project that the average number of people with non-melanoma skin cancer will increase from roughly 16,000 to 16,600 cases in men, and from just under 5,000 to 13,500 cases in women between 2015 and 2045. And we see this here in the graph above. And the first picture, so basal cell carcinoma is the most common form of non-melanoma skin cancer. It's almost 70%, or 7 in 10. It's generally very slow growing over months or years, and is usually diagnosed in middle-aged and older adults. It tends to appear on sun-exposed skin, so the head and neck, the face, the lower legs, the back, and the main risk factor is exposure to UV radiation. Notably, these cancers very rarely spread elsewhere. They can, over time, become locally invasive and may cause problems from that point of view. Squamous cell carcinomas are usually a little faster growing than basal cell carcinomas. Similarly, they mainly develop in sun-exposed skin, but they can develop anywhere in the body. They can also develop in skin that's been damaged for some other reason, so scarring or sunburn or ulceration. And they can appear in a lot of different ways. So as thick, rough, scaly patches that might crust or bleed. They can resemble warts or present as open sores that don't completely heal. Long-term chronic sun exposure is the leading risk factor for these cancers. These may become invasive, either locally, or they can spread elsewhere in the body and cause difficulties there. Finally, then, the third cancer I'm going to talk about today, melanoma. This arises from the melanocytes, the pigmented cells that give skin its color. It's much less common than non-melanoma skin cancer and accounts for only 9% of skin cancers overall. But excluding non-melanoma cancers, it's still the fourth most common cancer diagnosis in both men and women in Ireland, and it accounts for approximately 1 in 20 new cases. Over 1,100 people are diagnosed annually. The incidence, or the rate, in men and women is broadly the same. And similarly to non-melanoma cancers, its incidence is rising, especially in women. And again, over the next 15 to 20 years, it's predicted that the number of cases will almost treble from 1,100 to 3,100. The average age of diagnosis for melanoma is much younger than in many other cancers. There's a higher proportion of melanoma in people under 50 than any other cancer. And notably, the highest incidence is in the south and southeast, and you see this there in the 4 counties outlined in blue on the map on the right. Melanomas can be more serious than non-melanoma skin cancer, and so prevention and really early detection is critical. So then the causes, the risk factors. So I've listed out the risk factors here. Some can be changed, some can't. There's lots of overlap between the cancer types. And I'm going to go back to UV exposure. This is the main risk factor for both types of cancer. So looking at non-melanoma skin cancer, so previous history of other skin cancers or a family history of skin cancer, the classic Celtic pale skin that burns easily, people with a large number of moles or freckles, and immunosuppression or a weakened immune system, where medication can contribute to that, or sometimes somebody might have a condition or an illness that suppresses their immune system. Sunbed use is important here, and these cancers are commoner as people get older. Melanoma then is broadly the same. History of melanoma, other skin cancers, moles, many large or unusual or different appearing moles, and again, the classic pale complexion and a family history of melanoma. So looking at UV light exposure, this is probably the one that we all have the most control over. So exposure to UV radiation is the main risk factor for all of the cancers I've talked about. This is emitted naturally from the sun. It can be generated from artificial sources like sunbeds. And sunlight contains 3 types of UV light, so UVA, UVB, and UVC. The first two, UVA and UVB, damage skin over time, making it more likely for skin cancers to develop. UVC is generally filtered out by the atmosphere, so it isn't relevant here. Remember also that glass does not filter out all UVA rays, and this is particularly important when driving. Artificial sources of light, so sun lamps and tanning beds, also increase your risk of developing skin cancers, as does repeated sunburn, particularly in the context of melanoma and particularly in childhood. So I suppose just to mention that UV exposure doesn't just affect our risk of skin cancers, it also causes premature aging and can cause eye damage. So it's relevant in lots of different ways. And we can all limit our exposure in different ways. So the next 2 slides, the one in the center and on the right, talk about the UV index. So this is a very good indicator of when the sun is most dangerous. It measures the strength of the sun's UV rays, so you know when and how to protect your skin. And it's always strongest in the middle of the day, usually between 11 and 3, especially during April to September. It varies depending on where you are in the world, the time of year, the time of day, cloud cover, altitude, which makes a surprising difference, and surrounding surfaces. So reflective surfaces, water will increase the UV index. And remember, it's not always strongest when it's hottest. If it's anything at 3 or above, extra care and protection is required. And Met Éireann have a daily update on the UV index in Ireland, which is very well worth keeping an eye on. And so what can we do to reduce our risks? So the Healthy Ireland SunSmart 5S rule: slip, slop, slap, seek, and slide. So firstly, to slip on clothes that cover your skin. So long sleeved collared t-shirts. There's lots of protective clothing out there, especially for babies and children. And dark clothing is more protective than light. Texture and weave is also important. Next, to slop on broad spectrum, so UVA, UVB, sunscreen, water resistant if needed. Use at least factor 30 for adults and factor 50 plus for children, and reapply often. You don't have to spend a lot of money. What you do need to do is use what you have and use it liberally and often. So apply 20 minutes before going outside. For the average adult, we'd recommend usually 1 teaspoon for each arm and leg, for the front and the back of the body and the head. And remember, no sunscreen offers complete protection. So next, slap on a wide-brimmed hat to protect your face, ears, and neck. And slide on wraparound sunglasses with UV protection to protect your eyes. Also, don't forget babies and children here, if that is possible. Finally, seek shade, especially if outdoors between 11 and 3. Use a sunshade on a child's buggy and keep babies and children out of direct sunlight. So, how to prevent it? No sunbeds, and do not try to get a suntan. They're really the big 2. Avoid getting sunburned. Check the UV index if you're going to be outside, and check for skin changes regularly. So then, if you are worried, what happens? So basal cell carcinomas may present, and we see them here in the first 2 pictures on the left and in the middle. They may present with classically a pearly nodule, and we see that best here on the left-hand side. It's usually pink or white, and it may have little tiny blood vessels within it called telangiectasia. And again, we see that in the first picture. They can be ulcerated, they might have a rolled edge, and these generally grow very slowly. Over time, they may become crusty or bleed, and might look a little bit scaly, or can present as a scar or a white plaque with unclear borders, and we see that in the second picture. So these are different versions of basal cell carcinoma, same type of cancer, but they look very different. On the bottom right, we see a squamous cell carcinoma. So these are similar, but not the same. That said, sometimes you can't tell for sure what something is without a biopsy or a small sample to tell you for sure. And these may look like a nodule or a scaly bump that may be tender. They might bleed, and they can sometimes form an ulcer. And notably, some precancerous changes can also look very similar, so it's very important to get these checked out. Melanomas look rather different, and the first sign here is often a new mole or changes in an existing mole. So normal moles are usually round or oval with a smooth edge, and usually, although not always, they're no bigger than 6 millimeters wide, or the top of a pencil, like the eraser on the top of a pencil. So if you notice changes in a mole or a freckle or a previously clear patch of skin, especially if they're happening quickly over a few weeks or a month or two, go to your GP. Things to look out for: a mole that's getting bigger, changing shape or color, it's maybe bleeding or becoming crusty, or it's getting itchy or sore. Now, again, melanomas can develop anywhere in the body, but they most often appear in sun-exposed areas on man's back or a woman's leg. They're usually flat. They can occasionally be raised, but they're usually flat. But they can also develop elsewhere. So under a nail, on the sole of your foot, in your mouth, or in your genital area. But these are very rare presentations. And even more rarely, melanoma can develop in the eye. This is usually picked up because somebody has a new symptom, like a dark spot or a change in the vision, or just in a routine eye exam. So again, if you're concerned, go to your GP or your optician, and if there's any worry at all, they will refer you on to an ophthalmologist, a specialist eye doctor, for a formal assessment. So one way to help figure out whether a mole might be concerning is to look at a checklist called the ABCDE checklist. So the first one here is A, asymmetry. So melanomas tend to be asymmetric, unlike normal moles, which are normally rounded and very homogeneous. They have two very different halves, which we see here, and they're usually in a regular shape. B, for border, melanomas generally have a notched or ragged border. C, color. Again, melanomas are generally a mix of two or more colors and may have many different pigments in them. And D, diameter. They're usually larger than 6 millimeters wide, although that is not always the case. Finally then, evolution. Normal moles do not change, or virtually never change, but melanoma moles often change or evolve over time. They can change in size and shape and color, or they become raised or crusty. So if you are worried, what do you do? Go to your GP if you've noticed any persistent skin changes, or a lump that's tender or growing quickly, or you have a cut or a break in the skin that isn't healing. Most of these situations will not be something sinister, but please get checked out early just in case. If your GP is concerned, they'll refer you on to a dermatologist, a doctor who specializes in skin issues, or to a surgeon. They'll do generally a full skin examination. They won't just look at the area they're concerned about, they'll check you out. They'll often do a biopsy, which is a small sample, or they'll take the area that they're concerned about away completely. This is done under local anesthetic. It won't hurt. And then sometimes people might need other tests after that. So if somebody has a basal cell carcinoma, usually we don't need to do anything more than that. With a squamous cell carcinoma, we may need to do more scans or other investigations. And with melanoma, it's very personalized. There are lots of different treatments available to people with different types of skin cancer. There are pros and cons to all, and your team will take you through this. Sometimes, very often, in fact, one treatment is enough, and that's often surgery. Sometimes people need more than one treatment over time, and there are a lot of different specialties involved in the care and management of people with skin cancer, including my own. Again, once you've finished treatment, it's important to stay connected to your doctors and to keep an eye out for any changes. And if you're not sure or you're not clear, ask. So for non-melanoma skin cancer, there's lots of different ways to treat it, and surgery in varying forms is probably the commonest thing that we do here. So in most cases, surgery itself is enough to cure it. So an excision is a small surgery to remove the cancer with some surrounding normal looking skin. And sometimes somebody might need a skin graft to help close the wound. That's where the surgeon takes a patch of healthy skin from somewhere else and grafts it or lays it over the area where you've had your operation. And a flap is when they move or rotate some nearby skin into the wound, again, to help it heal. And you'll know going into your procedure what needs to be done, your surgeon and your team will discuss this with you in advance. There is another type of surgery called micrographic surgery or Mohs micrographic surgery. So this is a very specialized type of surgery where the surgeon again removes the cancer in a small area of surrounding skin. And in this case, the edges are immediately checked under a microscope. And if there's still some cancer at the edge or there's concern there's some left, you'll have a little more surgery and so forth and so on. And this process is repeated until there are no more cancer cells. In some cases, if the cancer is small and considered very low risk, we can do something called curettage, where the surgeon uses a small blade to curette or scrape off the cancer, and then they cauterize or burn, maybe zap the skin to remove any cancer cells that might still be remaining and to seal the wound. And this can be done a couple of times. Cryotherapy, similarly, is used again for small and low-risk cancers, but in this case, it's the other end of the spectrum. They use liquid nitrogen to freeze the cancer. This causes the area to blister and scab, and after a couple of weeks, the scab falls off. There might be a little tiny scar left, but usually the cancer is gone. Photodynamic therapy, or PDP, is a combination of using a cream that makes the skin sensitive to sun or to light, and a few hours after it's applied to any area that we're concerned about, the team will shine a strong light source on, and this kills the cancer. It may feel a little odd, it may cause a burning sensation and can leave a scar, but usually not as much as with surgery. Radiotherapy then. This is using low doses of radiation to kill the cancer cells. This can happen as a main treatment, or it can sometimes happen after an operation. And in that case, the idea is that it reduces further the risk of the cancer coming back. And finally then, medication, which is a broad church. So with chemotherapy, we rarely use tablet or intravenous chemo in this setting. More usually what it is a cream that's applied directly to very superficial cancers that are in the outer layer of the skin. That causes a strong local reaction that over time settles down and generally heals into smooth skin, and it avoids the need to take any medication internally, and thus there are far fewer side effects. Finally then, in selected cases in this situation, we can use immunotherapy and targeted therapy. These are treatments that in the first case harness your body's own immune system to treat the cancer. And with targeted therapy, it takes advantage of the fact that there could be changes or genetic mutations in some type of cancers that may be, I suppose, sensitive to specific medications. And these are used in this setting, although not very commonly. I'm not going to get into the melanoma treatment options in too much detail as it's so specific to the person's situation. I suppose just to say that things are changing enormously in the treatment of melanoma. There's a specialised group called the MDT, or multidisciplinary team, who come together regularly to discuss your case at many different points along the way. There's input from everyone, and treatment is very individualised on that basis. And people may also be offered the opportunity to enter clinical trials if they are suitable. Given that the treatment and the outlook has improved so much, particularly with the advent of immunotherapy, which has really changed everything for people with advanced melanoma, things are very different than they were 5 or 10 or 20 years ago for people in this setting, and the outlook continues to improve. So lastly then, innovations. And one thing I did want to mention was the Skin Cancer Prevention Plan. We're currently in the middle of the second one. This is a national plan, the first of which came out of the 2017 National Cancer Strategy. Really, it recognises the fact that skin cancers of all kinds are very common and will increasingly improve or become more common over time. And so it's really important both to increase awareness, catch them early, but most importantly to prevent them. So I suppose firstly, what does it want to do? It wants to increase awareness of how to prevent skin cancers. And really, it's not just sunscreen, there's lots of other things we can be doing. Secondly, to approve adoption of skin cancer preventive behaviours. So change behaviours in a way that people will do consistently over time to reduce their risk of developing a cancer at all. And there are 5 main target groups at the moment. So the first, children. Childhood sun exposure is particularly harmful. And we know that if a child has more than 3 severe sunburns during childhood, so before they're 20, it's associated with a 2 to 4 times risk of developing melanoma in later life. In adolescents and young people, we know there's a steady decline in sun protection behaviours in this age group. For outdoor workers, they probably have 2 to 3 times more UV exposure than indoor workers, so their risk over time is much greater. And in the sports, recreation, and tourism spaces, really it's about the promotion and awareness of the safe environment. Finally, then sunbed users. So sunbeds are classified as a Group 1 carcinogen by the IAEA. The age group between 15 and 35 are most likely to use sunbeds, and this is definitely a group for targeted intervention to raise awareness. So resources. It's important to, if you are looking for information, particularly online, to go to good, reliable sources of information. The HSE and the NCCP have very, very good information and resources online. There's excellent Irish charities and foundations, so the Irish Cancer Society, the Mary Keating Foundation, and the Irish Skin Foundation. They have excellent websites and their links are all reliable. Don't forget your local cancer support groups for anyone with a cancer diagnosis for their families. They're invaluable sources of support. And there's also very good resources online from the UK in particular. So I suppose don't forget all your medical teams, especially your GP and your friends and family as well as a source of support. And I suppose really then this brings me toward the end of my talk. And I found I always learn something when I do these talks. And I realized while putting this together that I personally have most of the risk factors for skin cancer that we discussed tonight. Some I can't do anything about, but I can change a lot of things. So using sunscreen regularly and avoiding significant sun exposure is key. And just as important, getting checked out early if anything changes is critical. So to the take-home key messages, prevention is the main goal. Everyone has some degree of risk. Firstly, you need to know about it. Secondly, there are lots of things that can be done to reduce this. And then early detection is critical. Get checked out if you're worried or unsure. We know that people who were diagnosed earlier do better with less treatment. And finally, then there are multiple treatment options available that are tailored to each individual situation. These are improving all the time. And so finally, this brings me to the close of my talk tonight. Thank you all for attending and for your attention. I'm very happy to answer any questions you may have. Thank you very much.
Thanks so much, Ciara. That was a great talk. It was really clear and really informative. I'd just like to remind our audience, if you'd like to ask any questions, there's a Q&A tab at the bottom of the screen. And just a reminder as well that this talk is being recorded in case you'd like to share it or link back in at any other time. We've had some great questions coming in already, and we're going to get to them now in a few minutes. So please just add them to the Q&A section if you'd like to ask anything else. So thanks very much, Dr. Lyons, Ciara, for joining me on the live Q&A session this evening.
Thanks, Mary, and thank you for the invitation for this in the first place. We've had some really good questions come through. I wonder, will we take them one by one and go from there?
Yeah, so I'll start going through them here and hopefully we'll get through as many as we can. So the first question in there is, what is immunotherapy?
So that's a really broad church. So immunotherapy is something that's being used more and more for people, usually with more advanced melanoma. It's also used in lots of other kinds of cancers. And basically what it does is it boosts your own body's immune system to fight or to counter cancer. So I suppose it's harnessing what you yourself are already doing and boosting that really. So it works in lots of different ways. It often works on T cells, so that helps your immune system fight off disease and infection. And in melanoma, the two commonest types of drugs we use are ones called anti-PD-1 or anti-PD-L1 and CTLA-4 inhibitors. So basically, they work differently and they often work together. We often give these drugs together, but the idea is that normally these two pathways in the cell help to switch off or slow down the immune system. And if we give anti-PD-L1 inhibitors or CTLA-4 inhibitors, you stop the immune system from switching off, and so you allow it to continue to fight back or to push back against the cancer. These drugs are generally given as an intravenous infusion. They can occasionally be given as a tablet and can be given alone or in combination. The side effects are usually quite mild, and we would go through these with you in detail before you would start any new drug like this. And really, any side effect is related to a heightened response of the immune system in some other way. So say a skin reaction or issues with energy or bowel bother, sometimes hormone changes, and you will be monitored very carefully for that as you went through treatment. But really, these have been game changers for people with melanoma, for people who are suitable for it. You'll be offered these drugs. You may be offered them as part of a clinical trial. And I suppose the common ones that we would use are ipilimumab, or Yervoy is the other name for that, and nivolumab or Opdivo is the common are the commonest two that we would see in practice. So if these are on the radar, you will have education, you will have written information, you will have ways of contacting your team if any issues arise, and you stay in regular contact with your medical team while you're on treatment. And they make sure you have all the information you need before you start.
That's great. Thanks very much, Ciara. Another question that's come in there is about Solarez, Solarez cream, and whether it's good for sun-damaged skin.
Great question. So this is something that's used often before you might get to see me. So it's very good. It's generally used for people with sun damage or precancerous changes, which is very, very common in Ireland for all the reasons we talked about. So it combines a combination of two different treatments. So a non-steroidal anti-inflammatory gel, which is actually a version of diphenol or diclofenac, which is sometimes a tablet that people take as a painkiller, and hyaluronic acid, which basically helps tissue penetration. It helps the drug get into where it needs to get into. And it works well. It will cause a fairly brisk skin reaction, as often many of these local treatments do, including radiotherapy. And things will look worse before they get better. It might look worse for a few weeks. So the skin can get quite red, quite crusted, get a bit sore. And that can last a couple of weeks, but usually settles down to normal skin. So what happens then is that sometimes that's it. That's all you need. Sometimes it can be repeated, either shortly afterward or months or years down the line, but it can be used over time and used very effectively. Something that doesn't settle down and doesn't go away with this treatment might need a bit more looking at. And sometimes that does become apparent over time. So you'd be monitored carefully if you're having any of those treatments.
Okay, that's great. Thanks, Ciara. So the next question there, the sun feels stronger at lower temperatures in Ireland compared to other countries in Europe. And I would burn quicker in Ireland at temperatures that I would not abroad. Why is this?
That's a good question. And firstly, can I just say it's great that you're aware of your risk and thinking about that in the first place, both whilst on holiday, but also at home in Ireland. So what I would say, I suppose we have long days in Ireland. We're quite northerly. We're at a high latitude, and there's a lot of wind exposure here that we don't ordinarily get in other countries. And to be fair, people are generally more diligent about their sun exposure on holidays. I said as part of the talk that I wear sunblock every day, even if it's raining as it is now. And I find that sometimes I'm quite prone to getting sunburn when it's a windy, rainy day, incredibly. So what I would say is that really points to needing to wear a sunblock pretty much and be aware of it pretty much all the time, particularly from the spring to the autumn, but really all year round.
Absolutely, yeah. I think it's that awareness, isn't it? And it's the light rather than thinking about the sun.
Exactly.
It's really
Exactly.
important people have an awareness of that. So another question there that's come in is, what is considered a serious burn in children, given you mentioned that 3 serious burns in children is a big risk factor?
So really any kind of sunburn in children is something to be avoided. And I realise very much that is easier said than done, particularly as they get older. So basically, if they've been out in the sun, if they're sick after they've been out in the sun, if they have a sunburn and they're unwell, they get a high temperature, or they're a bit shivery, or they're just a little bit off. If they're headachy, if they're sore, or if they start to blister, a blister is automatically a significant sunburn. So I think this is something that something that an awful lot of us were exposed to as children. I don't know if there's anyone who grew up in Ireland who hasn't had issues with this in the past. We can't do anything about that now. We can certainly improve our future risk, but we can absolutely protect our children as much as is feasible. So getting them used to wearing sunblock, wearing the UV protective clothing, keeping them out of the sun when it is high, and just having them being a little bit aware of it too, and how important it is to sunblock every day at school, that kind of thing. That's really important in building their own awareness of sun protection.
That's great. Thanks, Ciara. And another question in there. I have been told by complementary practitioners that there are awful chemicals in your typical sun lotions and creams, and that they in fact cause skin cancer. How true is this? Our question asks.
Okay, so that's an interesting one, and this is one that comes up every now and then. So what I would say is that we in medicine are all about the evidence. Everything we do, as far as possible, is evidence-based, and there is no evidence that sunscreen causes cancer. There are very tiny amounts of different chemicals in sunscreen that are very high concentrations, maybe carcinogenic, but really that goes for an awful lot of things, virtually everything we encounter in everyday life. So I suppose what I would say, we know that unprotected sun exposure really greatly increases your risk of a number of cancers, not just the ones we talked about today. And that, I suppose, the other thing that I would say, we live in the EU, which is very tightly regulated. We know all sun protection sold here goes through rigorous testing. It will not get to market if there is any concern. And that is it stays under review even after it reaches the market and it's in wide use. So from that point of view, I wouldn't have any concerns about using sunblock myself on children, on any family member, and would strongly, strongly encourage it. But would always encourage people also to ask questions and just use a reputable sunblock that's CE marked. That would really be key.
Absolutely, yeah. Thanks, Ciara. There's some more questions coming in there now. So just a quick one. Do you recommend mapping of moles?
Oh, that's a good question. So I think this is, I suppose, an extension of being aware of your own risk. There are some people with fair skin in particular who have an awful lot of moles, and I suppose it can be difficult to see all of your own moles on your back or the backs of your legs or what have you. So I think an awareness of your own skin and what's changing, and you may need a bit of help with that to get somebody to look at that and to keep an eye on that every so often. If you're concerned, have a chat to your GP. And if you're particularly concerned, it's worth considering. It's not for everybody, but it's certainly an extra layer of reassurance for people if they're worried about their risk.
Absolutely. Yeah, that's great. I think it's very individual as well, isn't it? You know,
100%,
everyone.
100%, absolutely. I think, again, the big things are awareness, sun protection, and then beyond that, the rest of it is a very individual decision.
Absolutely.
There's more coming in too. It's an interesting one. Should we be out in sunshine without protection to keep up our vitamin D levels? We, even with no sunblock, is 100%. So even with sunblock, it increases your protection, but it's not absolute. The only way to do that is to stay indoors without any access to windows, and who is going to do that? So your vitamin D levels are going to be fine. I think if somebody's managing to be out with a level of sun protection where you're worried about vitamin D, that's an incredibly difficult thing to do. Let me see. I'm looking here, somebody's asking about the staging of melanoma. Just say, can it stage from when you're first diagnosed to when you come out the other end of treatment? And yes, the stage can change. So a stage in cancer basically reflects the extent of the cancer when you've presented. So both locally in terms of where it starts and whether it's spread to lymph glands, which tend to be the next step, or beyond that to other organs. And so it absolutely can. The first biopsy in a cancer diagnosis is often to confirm the diagnosis. It may not be the full picture, and people may need more surgeries or more scans or a combination of those things to get a fuller picture of what's going on. So it can change. And sometimes over time, a cancer can return or appear somewhere else, and that in itself will change the stage. Just to say, some people with early types of skin cancer will need a very local treatment and no more than that. If there's a little more going on, particularly with melanoma, usually we will need to look more carefully in order that we can know what's going on. We can give somebody a prognosis, an idea of how they might expect to do, and we can then begin to choose the treatments available to them and tailor their treatment to them. That's increasingly important with all the treatments we now have available, and so we take great care to do that in that setting.
Yeah, and I suppose, Ciara, it's really that, people who are listening to us and who are online at the moment, the advice is really to check it, isn't it? To absolutely don't ignore things, and it's better to check, and it might be nothing, but it's better to go to the GP and actually,
checked out. Mary, that's exactly it. That's the take-home message. So what I say to people, be aware. The fact that you're all on in the first place is fantastic. That shows the level of sun awareness and that you have. And I suppose beyond that, anything you're worried about, get checked out. The vast majority of it will be nothing. But if it is something, the sooner we know about it, the better. Usually the easier it can be dealt with. And if there's nothing going on, the sooner your mind is at rest. So I hope all my GP friends will forgive me for saying this, but if you are worried, get checked out, and we'll take things from there. You'll be referred on if needs be, and the vast majority of things can be dealt with locally.
Absolutely. Absolutely. Okay.
That's probably, I think, the end of the questions.
Yeah,
Are we finished up?
Yeah, okay. I think that's all the questions. Thanks. I suppose take this opportunity to thank you, Ciara. That was a really great talk. So that's all the questions and answers that we have time for this evening. So again, thank you for sharing your expertise and being with us this evening, Dr. Lyons. It was really good to have you. If you'd like to speak with Ciara or any of the oncology team or get any more information about the services we have available, You can get in touch with us in Whitfield Hospital in the Hillman Cancer Centre in Waterford, or as I said, our sister Hillman Cancer Centre located in the Bon Secours Hospital in Cork. And we're very much here to help. So please do get in contact and use the link for this talk for any of either yourself or your family members. Before we do finish up this evening, we've one final video to share, which is a short, helpful presentation from Una Murphy, who is a nurse with the Irish Cancer Society. So it's a really quick video that we're going to finish up with, and it just kind of highlights, I suppose, the main points of awareness this evening and the main points that myself and Dr. Lyons have talked about. I'd also like to say on at UPMC, thank you so much for joining us this evening. We hope you have found it useful and reassuring. And the full recordings of both Ciara's and Una's talks will be shared with you by email and made available online shortly. So that's it from me. Thanks again for joining this evening, and I'm going to leave you with Una's presentation to close the evening. Goodbye and thank you.
Skin cancer occurs when skin cells become abnormal and grow in an uncontrolled way. The two types of skin cancer are non-melanoma skin cancer and melanoma skin cancer. Non-melanoma skin cancer may also be called basal cell cancer or squamous cell cancer, and is usually found in the outer layer of the skin. It tends to appear on the sun-exposed areas of your body, such as your head, face, arms and legs. Non-melanoma skin cancers can appear as a small lump that is smooth, pearly or waxy, a flat red spot that is scaly, crusty or bleeding, a lump that is rough, scaly or has a crusted surface and may be sore, or as rough, scaly, irregular patches. Skin changes are not always skin cancer. Spots and sores are common, but it is important to talk to your doctor if you notice anything unusual. Non-melanoma skin cancer is the most common cancer in Ireland. The number of people being diagnosed with skin cancer is rising, yet skin cancer is largely preventable by protecting your skin. Your risk of developing a skin cancer is increased if you have been exposed to UV rays from the sun, use sunbeds or have ever used a sunbed, if you have pale, fair or freckled skin that tends to burn easily, or have grey, green or blue eyes, if you have a change to an existing mole and a lot of moles, if you had a severe sunburn as a child or adolescent, if you have had a previous skin cancer or a close family member who has had skin cancer, if you work outdoors, or if you have a weakened immune system. People with dark or black skin have less risk of sunburn but can still develop skin cancer from UV damage. Many skin changes are harmless. However, if you notice a change or are worried about a mole, the first step is to go to your doctor. This is important. Your doctor will do a skin examination. You may then be referred to a skin specialist called a dermatologist for further tests. The dermatologist may decide to do an excision biopsy. This means the entire mole or affected tissue is removed and examined in the laboratory to determine if it is cancerous or not. Excision biopsy is often the only treatment needed for non-melanoma skin cancer. Some people may need additional treatment. The other main type of skin cancer is called melanoma. It occurs in skin cells that make melanin. Melanoma is a more serious skin cancer than non-melanoma because of the ways it develops and its ability to spread. Melanoma can appear as a mole that has changes in colour, size and shape. Melanoma mainly develops in moles, but it can develop in other tissues and parts of the body, such as the eye, feet and nails. So remember to check these areas of your skin when you're checking for moles and changes in your skin. The main treatment for melanoma skin cancers is surgery to remove the mole and area around it. This can usually cure it. Treatment may also include chemotherapy, immunotherapy, targeted therapies or radiotherapy. Remember, checking your skin regularly or asking your doctor to examine your skin is a very helpful way for you to notice any skin changes. You should photograph any suspicious moles to help keep track of any changes. Talk to your doctor if you notice anything unusual. You can check your skin for any skin changes or new moles by examining your body front and back in the mirror, then your right and left sides with your arms raised. By bending your elbows and looking carefully at your forearms, underarms and palms. and looking at the backs of your legs and feet and the spaces between your toes and soles. You can check the back of your neck and scalp with a hand mirror, parting your hair for a closer look. Also check your back and buttocks with a hand mirror. Be sun smart, because 9 out of every 10 skin cancers are caused by UV rays from the sun. Remember to seek shade, cover up, wear wraparound sunglasses and use sunscreen. Spotting cancer early is important. Learn what to look for and check your body for changes. Talk to your doctor if you notice anything unusual for you. For more information about skin cancer, go to our website cancer.ie/skin. You can also call our support line free of charge and talk to one of our cancer nurses on 1800 200 700. Or you can email our cancer nurses on the support line at support@irishcancer.ie.